Phases of menopause, all of us are knowing. The pre-menopause, the period of regular cycles, then the perimenopause. Perimenopause is actually a period which starts 3 to 5 years before the menopause and it continues for 12 months after the final menstrual period. And you will see that most of the patients will be coming to you during this phase with various complaints of menopause. And post-menopause, we already know, time period starting 1 year after the last menstrual period. So, coming to the endocrine changes at the menopause, decline in the number of follicles starts in fetal life and the rate increases by approximately 38 years, reaching a critical level of 25,000, and then the fecundity begins to decrease. So, menopause will occur at a critical threshold of 1,000, regardless of the age. So, don't think all the follicles are finished. When you reach a critical threshold of 1,000, the periods will stop. So, FSH level more than 10 international unit per liter is suggestive of declining ovarian function. More than 20 international units suggestive of ovarian insufficiency, usually seen in the perimenopausal group, and more than 40 done twice at least 4 weeks apart is a reliable marker for menopause. Now, this is a old thing which we already know. At the onset of puberty, there is activation of hypothalamic pituitary axis, release of FSH. This FSH will act on the ovary, so the follicular response will start. Now the ovary will release inhibin, estradiol and the androgens. Another source of estradiol in our body is the androgens which are released by the ovary as well as from the adrenal gland, and the peripheral aromatization of these androgens also leads to formation of estradiol. So now we see what happens post-menopause. In post-menopause, so what the difference you can see here, this arrow is slightly thin. Thickness of the arrow shows the increase in level. Inhibin was present here, but now it is not there. Estradiol, which was being produced by the ovary, is not there. Only the estradiol, which is formed by the peripheral conversion of the androgens, is there. So the negative feedback effect of inhibin mainly is stopped, and due to which the FSH level rises. So is the culprit inhibin or estradiol? What do you think? Who is the culprit? Estradiol is not there, so FSH rises, or inhibin is not there, so FSH rises. We all believe estrogen is the culprit, but estrogen is not the culprit. The culprit is actually inhibin. So inverse and tight relationship between FSH and inhibin indicate that FSH measurement is a reflection of inhibin. The decrease in inhibin secretion begins around the age of 35 but accelerates after 40 years of age, paralleling the decline in fecundity. So this is the reason why when we are giving MHT, so what do you think? When you are giving estrogen and progesterone or only estrogen, so if estrogen is the culprit, then the FSH level should come down. But it is not. Why it is not? Because actually estrogen is not the culprit for this. The main reason is inhibin, which the ovaries have stopped producing. So even if you are giving MHT, you are giving estrogens, the FSH levels will not come down. So the take-home message here is FSH levels cannot be used to titrate estrogen doses in menopausal women on hormone therapy. You start the hormone therapy, don't believe that after 3 months the FSH should come down or your treatment is not acting, because FSH will not come down because it is based on the effect of inhibin only, not estradiol. So for easy remembrance, I have made this. The major types of estrogen in the body, E2, that is the estradiol. Estradiol is the most potent estrogen, which is the estrogen of reproductive period. So just for remembrance, see, estradiol has di. Di means two, involves two persons. So a couple is involved during the reproductive period. So you can easily remember that E2 is the hormone of reproductive period. Then E3 has the word tri, estrol. So it is the estrogen of pregnancy. So 3 lives are involved, husband, wife and the baby. So you can easily remember E3 is the estrogen of pregnancy. And the third one is estrone, that is 1. So it is the estrogen of menopause, when the female is alone during menopause. So you can say E1. So what is the difference between mainly potent is E2 and then E1? The difference is that estradiol is produced both by the ovary as well as from the androgen, as we have seen in the last slide. But the E1 that is the estrogen of menopause, is only produced by the peripheral conversion of the androgens. So this is the difference. That is why during reproductive period, the ratio of E2 to E1 is 2:1, and this ratio changes to 1:2 during the menopausal period. That's why E1 is known as the estrogen of menopause, whereas E2 is known as the estrogen of reproductive period. So this will be more clear from this chart. So if you see this, with the decline, this is the FSH green line. With the decrease in inhibin level, this FSH gradually increases, reaches a peak about 1 to 3 years after menopause. This is the final menstrual period. So it reaches a peak 1 to 3 years after menopause, after which there is a slight decline and then it stabilizes. Similarly, following it, the LH level. But the difference is the LH level you see is constant. It is not increasing earlier as FSH. The LH level starts increasing only about 1 to 2 years before menopause. It also increases, but the peak is less as compared to FSH. While the FSH level increases 10 to 20 fold, the LH level is increasing only 3 to 4 fold. So what is the reason for this difference? Why only FSH is increasing and LH is not increasing? This is because LH is a shorter half-life. It has a half-life of only 20 minutes. So it is cleared from the circulation earlier, while FSH has a half-life of about 3 to 4 hours. So it attains a more peak, and there is a 20 to 20 fold increase in FSH as compared to LH. Moreover, there is no specific inhibitory factor like inhibin, the negative feedback by inhibin, that is specifically for FSH. So loss in that feedback also leads to increase in FSH, which is not there in LH. So the peak in LH is low as compared to FSH. Following this, the estradiol levels we can see. The estradiol level also, the decline starts only 1 to 2 years before the menopause. In the initial years, it may remain stable, or sometimes with the increase in FSH, it may sometimes show peak also. Because with the increase in FSH, sometimes more recruitment of follicles is there in some of the cycles. So in some cycles, you may get a report like FSH is also increased and estradiol is also increased. So you will be confused, how come it is possible? FSH is increased and estradiol is increased. But this can happen in the early phases. Then finally this decline starts and it reaches a level about 10 to 20 picogram per ml. Now this is estrone. For the decline in estrone is also there, but this decline is less as compared to estradiol. So this is the reason that the ratio of estradiol to estrone changes, because estrone is only from androgens. So the ovarian failure has no role in the decline in the estrone, only the reduction from the androgen part is there. So that's why the decline is there, but still it becomes more than estradiol. So this is the hormonal variations which we usually see. Now we come to the levels. If you see, estradiol, which is the pre-menopause period, 40 to 400 picogram per ml may decrease to 10 to 20. Estrone, which was 30 to 200, comes to 30 to 70. So see the difference. The fall in estrone is not so much as compared to estradiol. So the ratio changes. The testosterone level, there is about 25% decline only. 20 to 80, it goes down to 15 to 70. That's why we can say in menopause there is a relative androgen excess, because the fall in testosterone is not much as compared to the estrogen, and the androstenedione levels, they decrease by almost 50 to 60%. So this is the major change in the hormones. So once you have understood these hormones, we come to the straw plus staging. This straw plus staging is a special staging of the menopause. Our own Dr. Behram Ankaleshwar sir has done a lot for this also. He had also given a separate staging for the menopause. Now if we consider, if you try to understand this, this is taken as the reference point, that is the final menstrual period. After this, the whole lifespan of women is divided into 3 phases: reproductive phase, transition phase, and the post-menopause phase. So, and each of the phases is divided into different stages. So, if you, the things which we have taken care is the clinical profile, that is the menstruation, the biochemical findings, that is the AMH, inhibin, FSH, and the ultrasound findings of the AFC count. So, the first -4 and -3 is the normal period. Now, if we consider -3 stage, so -3 stage is the stage when the changes start occurring in the reproductive period. So, in what happens in -3B? In -3B, The patient may come to you with patient may be having normal cycles. There will be no rise in FSH, but if you see the AMH may be slightly low, then the AFC count may be slightly low. So no clinical symptoms, but the AMH may be low and the AFC may be low. Then when you go to -3A stage, the patient may come with shorter cycles and a slight increase in FSH, and the AMH and inhibin levels will keep on falling. So after this, we go to the transition phase. So what happens in transition phase? In the last phase, the cycles had become shorter. Now what will happen? The cycle irregularity will increase gradually. So there will be more than 7 days difference in the cycles. Sometimes the cycle may be of 22 days, sometimes may be of 42 days. So normal cycling, shorter cycles followed by irregularity of 7 or more days. Then when you come to stage -1, that is not 0-1, that is -1, in that stage there will be missed periods. Now starts the amenorrhea. So the period patient may come to you with 2 months amenorrhea, 3 months amenorrhea, so more than or equal to 60 days of amenorrhea. And following this, the levels of AMH and inhibin will decrease while the FSH will increase. Most of the patients come to us during this period, and in this is the period when the vasomotor symptoms, that is the hot flashes, are the most common. So patient may come to you with menstrual irregularity and hot flashes, and we may think she is not in menopause, but these symptoms start occurring before menopause, 2 to 3 years before menopause. Then comes the final menstrual period. After that we go to the post-menopause period. In the +1 stage, what happens? The patient has already become amenorrheic, but the FSH levels will continue to rise, because as I said, the FSH level continue to rise for 1 to 3 years. So the FSH levels will continue to rise, and the patient will be experiencing symptoms like vasomotor symptoms. There will be decline in the bone density, and then the stage 2, which comes around 5 to 8 years after menopause. In 5 to 8 years after menopause, the patient may have improvement in the VMS. The patient who was having hot flashes for the initial 3 to 4 years, now she may say, now I am not having hot flashes, but now she will be having different symptoms like the genitourinary syndrome of menopause, and she will be at risk for osteoporosis, cardiovascular diseases, and in this stage you will see that the FSH will be stable. So this is the various stages which you may come across the patient. So something about menopause transition or the perimenopause. It is a period lasting for 3 to 4 years before the final menstrual period, up to 12 months after the last menstrual period. So mind it that despite menstrual bleeding, the FSH can be more than 20 international unit per liter, but LH may be in the normal range. As we had seen in that graph, that LH was stable for a long time. It increased only 1 to 2 years before menopause. So patient may come to you, she may be bleeding irregularly, FSH can be more than 20, LH in the normal range. So the thing is that unexpected pregnancy can occur. So you can't, if FSH is more than 20, so you can't assure the patient now there is no need for contraception. Because pregnancy can occur until persistent elevated levels of both FSH more than 25 and LH is more than 30. So LH is mainly you have to see for assuring the patient regarding pregnancy. Otherwise we will say कि FSH 20 हो गया अभी कुछ नहीं होगा चलेगा. But it is not there. Patient may come to you with pregnancy. So contraception should be recommended until post-menopausal state is established. So this is a chart of seeing with what symptoms the patient may come to you at what age. So between 40 to 50 years, the patient may come to you with menstrual disorders. The patient may be complaining of vasomotor symptoms, due to which there may be sleep disorders, there may be mood disorders. The symptoms like vaginal atrophy, dyspareunia, skin atrophy, these symptoms usually come after 5 to 8 years of menopause. So the patient will be usually coming after 55 years of age. At that time the patient may complain of vaginal atrophy, dyspareunia and skin atrophy. While the late complications will be osteoporosis, atherosclerosis, coronary heart disease and cerebral vascular disease. So the main usual first thing the patient may come to is abnormal uterine bleeding. And when the patient in perimenopause or menopause comes to us with abnormal uterine bleeding, the main dilemma is when to go for endometrial sampling. Because the thing is we have to go for it or not. So the incidence of postmenopausal bleeding is 10 to 15%, and women with postmenopausal bleeding have 10 to 15% chance of endometrial carcinoma. So when to go for endometrial sampling? See, women with postmenopausal bleeding and endometrial thickness more than 4 millimeter. So you have to go for endometrial sampling. Asymptomatic postmenopausal woman with ET more than 11 millimeter. Means sometimes the patient may have gone for a sonography for a calculi or some abdominal thing, and in that you may find that the endometrial thickness is 12 millimeter and the patient is postmenopausal. So even if the patient is not bleeding, you have to go for an endometrial sampling because 11 millimeter is the cutoff for asymptomatic postmenopausal women. So women with postmenopausal bleeding but ET less than 4 millimeter do not require sampling unless they are at high risk of endometrial carcinoma, because most of these cases are because of atrophic endometritis. So you may not go for sampling, but then you have to assess the patient regarding the risk for endometrial carcinoma. If the patient is obese, if the patient is having hypertension, patient is diabetic, then go for it. It is not a rule not to go. So persistence of abnormal bleeding. The ET was less than 4 millimeter, there was no risk factor, you did not go for endometrial sampling, but the patient continues to bleed. Means he had episodes of bleeding, go for sampling. Okay, repeated evaluation is required. Sometimes we do a DNC and then the report comes, tissue insufficient for diagnosis. We get the reports. Okay, so what to do? If ET was less than 4 millimeter, follow-up is sufficient. But if the patient is bleeding, again, if recurrent episodes is there, you need a hysteroscopy or further investigation. So hysteroscopy is the gold standard, especially for suspected focal lesions. Additional procedures like colposcopy and cervical biopsy to rule out any cervical cause. Can you tell me, I hope all are awake. So can you tell me what is abnormal in this picture? Can you find something abnormal?
Yeah, hot flush patient.
Okay, so this is a cold environment when there is snowfall is there and everybody is wearing jackets and all, while this woman is going with a fan on and wearing minimal clothes. So this is the condition in hot flashes when you are sitting in an AC and you are getting hot flashes. So we come to vasomotor symptoms, includes hot flashes, cold sweats and night sweats. Abrupt onset of warmth that begins in the upper chest, neck and spreads to the face may be associated with redness and sweating that lasts for a few seconds to several minutes. It is due to rapid vasodilatation of the skin blood vessels associated with increase in metabolic rate and heart rate and reduction in the skin resistance. And incidence increases typically during the perimenopause, reaching highest during first 2 years of menopause and then declines gradually. It may be mild, that is the patient may complain of feeling of heat without sweating, moderate feeling of heat with sweating, and severe feeling of heat with sweating and palpitations that disrupts the usual activities. So what is the use of this grading? Because based on this grading, we decide whether this patient has to be given for the hormonal therapy or not. Because the patient having mild symptoms, maybe there will be lifestyle changes and all that, but the patient having severe symptoms has to be given hormone therapy. So because of this, it may be associated with insomnia, irritability, tiredness, forgetfulness and inability to concentrate. So this may be the condition. This is for husbands sitting here of menopausal patients. So menopause in progress, go around and do not make eye contact. But with proper counseling, with proper treatment, you can convert to this. I used to be hot in my 20s, but now it comes in flashes. So patient is even happy with hot flashes. So this is a clinician's role. He has to turn the attitude also. The psychological counseling of the patient is must for menopause. Patient should be ready for this. She should have a positive attitude. Then only you can treat menopause. So we want a change. So the role of a menopause consultant is in between to change this. So the next thing is, with the patient may come to you is gynaecologist syndrome of menopause. Initially the term vulvovaginal atrophy was being used for this, but nowadays the Menopausal Society has changed the name to gynaecologist syndrome of menopause. It includes all the clinical signs and symptoms associated with the fall in estrogen level involving the vulva, vagina, vestibule, labia minora, labia majora, urethra and bladder. So all these things have been now included in gynecological syndrome of menopause. So the main thing with the patient comes to us is vagina disc. So what happens in this? The normal vagina is a multi-layered squamous epithelium which is made up of the paravasal cells, intermediate cells and the superficial cells. Now these superficial cells have glycogen stored in them due to the effect of estrogen. And the dodolens lacti bacilli which are present in the normal vaginal flora, they act on this glycogen and convert it into lactic acid. So creating a acidic pH. So the pH is around 4 or 4.5. But what happens in the absence of estrogen? This superficial layer, there's a decrease in the superficial layer while the paravasal cells increase. So what happens? No superficial cells, no glycogen, so no lactic acid formation. So the pH increases. So the pH now becomes alkaline, and this alkaline pH predisposes the woman to more of bacterial infections. So there is more chances of recurrent vaginitis. The patient may come to you. Moreover, the vagina, which was full of rugosities, which was pink in color, now becomes pale. And sometimes the vagina becomes thin. The patient may come to you with petechiae also. Just before 1 week, I forgot to take the picture. I saw a patient, she was 71 years old, and she was having full petechiae in the vagina. Typical the thing of severe GUSM. And I prescribed her Primarin cream, and within 7 days the vagina was healed. It was so good. So this is the thing which you can get. Now estrogen deficiency may lead to lack of collagen in vagina, which may lead to narrow vagina and dyspareunia. The atrophic bladder and urethra, this will be taken by our speaker. The estrogen receptors in the bladder trigone and urethra aid in increasing the sensory threshold when the bladder becomes distended, so that a woman can hold urine even if bladder is distended. But lack of estrogen, decreased sensory threshold may lead to urgency. The fall in estrogen level is not much associated with stress urinary incontinence. It is mainly associated with sensory urgency, because this is the reason. So now we come to cardiovascular health. During reproductive years, women are protected from the cardiovascular diseases and lag behind men by 10 years. So if you see on this chart, this is the incidence in female and this is in male. By the age of 54, the incidence gradually starts increasing, and at the age between 65 to 74, the rate is almost the same, and after 75, the females are at higher risk of cardiovascular diseases as compared to male. For MI and sudden death, females have a 20-year advantage before menopause, and this is mainly accountable due to high HDL levels, due to high estrogen and low level of testosterone. So postmenopausal women have a twofold higher risk of developing CVD than the premenopausal women. Natural premature menopause less than 35 years has a 2 to 3-fold increased risk of MI, whereas bilateral oophorectomy less than 35 years 7 times increased risk of MI. Now can anybody tell me what is the difference in between these two? Natural premature menopause 2 to 3-fold increase, while bilateral oophorectomy 7 times increase. Why it is so?
Because there is no androgen that is converted into the.
So that is the take-home message. That even in perimenopausal or even in postmenopausal, early postmenopausal women, if there are no significant risk factors, don't remove the ovary. We think 49 years age hai, હવે તો ovary જવાની છે, ચાલશે, કાઢી નાખો. No. The estrogen may be stopped, production of estrogen is stopped, but the androgens are being produced by the ovary, and these androgens will be converted to estrogen in the body. So you are depriving the woman of that estrogen, extra estrogen which she can get by removing that ovaries. So never do that. Oophorectomy will increase 7 times the increased risk of MI. So increase in total cholesterol and LDL occurs within 1 year interval of the final menstrual period. So estrogen protects the cardiovascular health by improving the carbohydrate and lipid metabolism, regulating coagulation and fibrinolysis, and effect on vascular and smooth muscles. Some changes in the body composition which you may see. There is a decrease in bone mineral density, that is the osteoporosis, loss of muscle mass, that is the sarcopenia, loss of cartilage leading to osteoarthritis, the shift of adipose tissue to visceral compartment. This is the main thing which is harmful. That will increase the cardiovascular risk. Menopause transition is associated with preferential increase in fat centrally as intra-abdominal fat and in gluteofemoral region. So you have to measure the waist circumference of the patient. If the waist circumference is more than 72 centimeter, the patient should be this is the alarming line, when the patient should be asked to avoid weight gain or start losing weight. But if the waist circumference is more than 80, then she needs supervised weight management. This is according to the ideal scenario. And this is the usual thing that our patients come. Why does it take 6 weeks to lose 5 pounds but only 1 day to gain it back? This is our problem also.
Yeah.
So now we come to osteoporosis. It is potentially the most serious long-term consequence of menopause. The peak bone mass is achieved in the 3rd decade of life. So we have to start caring for our bones from the 3rd decade of life, because after that the bone mass density will start falling. It is not only after menopause you take care, you have to start it early. So the prevalence of low bone mass is more than 40% from the age of 40 years, 62% by 60 years and 80% by 65 years. And mind it, osteoporosis is asymptomatic unless fracture occurs. So when fracture will occur, then you will come to know that you have become osteoporotic. So better to rise early. And so is the need for early diagnosis and timely management. We usually assess the patients for osteoporosis by visual risk assessment tools like FRAXA, OSTA, etc. Now the gold standard in diagnosis of osteoporosis is by assessing the bone mineral density by doing the DEXA scan. So in whom DEXA scan is indicated. Ideally all postmenopausal women more than 5 years of menopause should go for a DEXA scan. The postmenopausal women less than 5 years of menopause with risk factors like low BMI, previous history of fracture should go earlier. Radiological evidence of osteopenia and presence of vertebral compression fracture, go for a DEXA. And this is important. Women in menopause transition with secondary causes. Suppose the woman is coming to you and she is on long-term glucocorticoids. She is an alcoholic, she is a patient of rheumatoid arthritis, inflammatory bowel disease, thyroid dysfunction, go for an early DEXA. Because these patients' bone mineral density will decrease before the age of 50. So you don't have to wait for menopause and 5 years after menopause, go for an early DEXA. Women with fragility fractures and before starting the pharmacotherapy for osteoporosis. So how will you interpret DEXA? We have asked for a DEXA. DEXA scan is usually done of lumbar spine, femoral neck or total head. Two scores are there, T-score and Z-score. Now T-score is the number of standard deviations that the patient's bone mineral density is above or below the young adult reference mean. The normal T-score should be more than or equal to -1. Osteopenia is when the score is between -1 and -2.5, and osteoporosis when the T-score is less than or equal to -2.5. Now Z-score is the number of standard deviations above or below the reference mean of age-matched group. In that we were taking young adult as the reference. In this we are taking a person of the same age. So this will help. What this will help us? This will help us in finding the causes of secondary osteoporosis. So it is not age related, but it is due to some secondary causes. So if you are suspecting a secondary osteoporosis, you have to look at the Z scores. So Z scores less than -2 are said to be below the expected range. This is a type of report. This is a report of one of my patients, which you get in the DEXA scan. See, they are giving the bone marrow density. The color is not shown in this graph. The upper is usually green, which is the normal. Then comes the osteopenia, which is yellow in color, and then the red colored osteoporosis. So this is the DEXA of lumbar spine. In this patient, you can see the T-score was -3.3, -3.3, -2.3, -2.9, -2.9. And the Z scores were also low, all were below -2.5. So this patient was a patient of osteoporosis. So I'd like to discuss this case. This patient was around 54 years patient. She was a patient of severe backache, being treated by the orthopedicians. The X-ray was normal, and she was being given calcium for 6 to 8 months, but no response. Then we went for a DEXA scan in this. The DEXA, this is a report of that patient. So the DEXA scan showed this picture. Seeing the Z scores, we suspected some secondary cause also for this osteoporosis because the Z scores were below -2. So we did a parathyroid hormones and other investigation. That patient turned out to be hyperparathyroid and she was having a parathyroid tumor. So that patient then underwent the surgery for that parathyroid tumor. So the parathyroid hormone became normal and finally all this cycle was normalized. So the reports which were getting it, the T scores and Z scores were low, but the serum calcium levels was coming to be normal. Because what parathyroid hormone does, it drains the calcium from bones to the blood. So the blood level serum calcium is normal. So you believe serum calcium is normal, so what's the use of giving calcium also? But the culprit was the parathyroid tumor. So in this way, with proper interpretation, you can come to a diagnosis. So this patient was diagnosed to be having a secondary osteoporosis. So we don't want our patient to be having this. The husband is finding bones all over the house and the wife is chill. My doctor says bone loss is normal at my age. Mental health will be taken by a speaker, so I am not going into details. Something about the ocular health. The estrogen and androgen receptors are present on corneal and conjunctival epithelium and the meibomian glands. So the most common symptom with the patient may come is dry eye. And the one thing that you should keep in mind is for patients having the premature ovarian insufficiency, the patient early menopause may be associated with an increased risk for glaucoma and macular degeneration. So if the patient, any patient comes to you having premature ovarian failure, then send that patient to an ophthalmologist for frequent visits for early detection for glaucoma. In this way you can help your patient. Skin and hair, we already know. Skin thickness is reduced with increasing menopausal age. Up to 30% skin collagen loss during the first 4 years. The skin is dry and easily traumatized, causing itching, and the relative androgen excess may lead to hirsutism. So something about premature ovarian insufficiency, oligomenorrhea or amenorrhea for at least 4 months with FSH more than 25 on 2 occasions more than 4 weeks apart, usually before the age of 40 years. Now you cannot diagnose the ovarian insufficiency by AMH and AFC because AMH can be undetectable for as long as 5 years before the period cease. So you cannot say AMH is down so she is going in failure. 5 to 10 years may go ahead. Then in AFC also, the follicles identified are already at an advanced antral stage. So size of primordial follicles cannot be determined. So these can be just, you can use as predictors, but not for diagnosis of premature ovarian failure. And these are the candidates these are candidates for the hormone replacement therapy. Because they are losing their estrogen from the age of 35 or that. So if you are not giving HRT to these persons, then they will be at more of risk of osteoporosis, cardiovascular diseases. So long-term risk will increase, as we have seen earlier. So there is increased risk of cardiovascular diseases. Now something delayed menopause. Menopause occurring at 55 years or thereafter. The factors associated may be familial, reduced physical and mental stress, regular exercise, balanced diet, and obesity. Medical disorders like fibroids, hormone-producing tumors, etc. It has both the pros and cons, protective against osteoporosis and CVD, increasing the life expectancy, but on the other hand, there will be high risk for uterine, ovarian and breast malignancies. So they have to be screened properly, patient having delayed menopause. So the slogan of IMS is fit at 40, strong at 60 and independent at 80. So we all have to work together to make this slogan a reality. So each woman needs an individualized health plan management. It is most important to distinguish between a symptomatic and asymptomatic woman. Both of them need your care. An asymptomatic woman needs preventive health care. You have to screen her for various things and you can help her in that way. So the patient may present at menopausal clinic with menstrual problems, menopausal symptoms, general health for a general health checkup, or it may be an opportunistic contact to be picked up by the clinician. So it is up to you, so how much women you help. So you must be like this, he's a menopausal practitioner. So he's saying, chill out people, I'm handling it. So you don't have to worry about menopause now. And I'm sure after completion of this CME, all of you will be like this. Chill out people. Thank you so much for a patient hearing. I hope I made it.